We can start now. Today, we are going to start an important academic session of MR Bangur Hospital. And today is the seminar on shock. 3 speakers are there, Dr. Diptoman, Dr. Berur, and probably Dr. Srija Rai. Okay, so we can ask the first speaker who will speak on classification and pathophysiology of shock. In the meantime, hope if the connectivity is good, Professor Saha can join because he is traveling. So we hope everything will be okay so that we get Professor Saha in this very important seminar. So I request the first speaker to start his part, that is classification of shock. Classification and pathophysiology of shock.
Diptaman, you are not audible.
Hello.
Hi, yes, you are audible.
Yes,
Please
yes.
start.
Diptaman, please start.
Yes, sir. I'm going to describe classification and pathophysiology of shock. Now, first, the definition of shock. Shock.
You are muted again, Diptaman.
Shock at its most rudimentary definition and regardless of the etiology is the failure to meet the metabolic needs of the cell and the consequences that ensue. The initial cellular injury that occurs is reversible. However, the injury will become irreversible if tissue perfusion is prolonged or severe enough such that at the cellular level, compensation is no longer possible. Next slide, please. A modern definition and approach to shock acknowledges that shock consists of inadequate tissue perfusion marked by decreased delivery of required metabolic substrates and inadequate removal of cellular waste products. This also involves failure of oxidative metabolism that can involve defects of oxygen delivery, transport, and/or utilization. Next slide, please. Belloc proposed 4 categories of shock. This was initially the 4 categories of shock that was prescribed. That is hypovolemic, vasogenic, cardiogenic, and neurogenic shock. Hypovolemic shock is the most common type, which results from loss of circulating blood volume. This may result from loss of whole blood, plasma, interstitial fluid, and/or a combination. Vasogenic shock results from decreased resistance within capacitance vessels, usually seen in sepsis. Neurogenic shock is a form of vasogenic shock in which spinal cord injury or spinal anesthesia causes vasodilatation due to acute loss of sympathetic vascular tone. Cardiogenic shock results from failure of the heart as a pump, as in arrhythmias or AMI. However, in recent clinical practice, further classification of shock has described 6 types: hypovolemic, cardiogenic, septic, neurogenic, traumatic, and obstructive. So 2 more additions are there to the previous classification. And these 2 additions are obstructive shock and traumatic shock. Obstructive shock is a form of cardiogenic shock that results from mechanical impediment to circulation, leading to depressed cardiac output rather than primary cardiac failure. This includes etiologies such as pulmonary embolism or tension pneumothorax. In traumatic shock, soft tissue and bony injury leads to the activation of inflammatory cells and the release of circulating factors such as cytokines and intracellular molecules that modulate the immune response. Next. Now we come to pathophysiology of shock. The initial physiologic responses in shock are driven by tissue hyperperfusion and the developing cellular energy deficit. This imbalance between cellular supply and demand leads to neuroendocrine and inflammatory responses, the magnitude of which is usually proportional to the degree and duration of shock. The specific responses, however, will differ based on etiology of shock, as in various etiologies. There can be some different responses, as certain physiologic responses may be limited by the inciting pathology. So according to the pathology or according to the etiology, the pathophysiology can be different. Next slide, please. For example, the cardiovascular response given by the sympathetic nervous system is markedly blunted in neurogenic or septic shock. Additionally, decreased perfusion may occur as a consequence of cellular activation and dysfunction, such as in septic shock and to a lesser extent traumatic shock. However, many of the organ-specific responses are aimed at maintaining perfusion in the cerebral and coronary circulation. Next slide, please. Furthermore, the pathophysiologic responses vary with the time and in response to resuscitation. In case of hemorrhagic shock, the body can compensate for the initial loss of blood volume primarily through the neuroendocrine response to maintain hemodynamics. This represents the compensated phase of shock. But as the hypoperfusion continues, which may be unrecognized initially, cellular death and injury are ongoing, and the decompensation phase of shock ensues. Next, microcirculatory dysfunction, parenchymal tissue damage, and inflammatory cell activation can participate hypoperfusion. Ischemia or reperfusion injury will also exacerbate the initial insult. These effects at the cellular level, if untreated, will lead to compromise of function at the organ system level, thus leading to the vicious cycle of shock. As the hypoperfusion continues or persistent, it leads to further hemodynamic derangements and cardiovascular collapse. This has been termed the irreversible phase of shock. Now, this is a pathway leading to decreased tissue perfusion and shock, which I will explain in the later slide. This is the decreased tissue perfusion can result directly from hemorrhage, hypovolemia, cardiac failure, or neurologic injury. So these are the some predisposing factors like hemorrhage, hypovolemia, cardiac failure, or neurologic injury, which can lead to decreased tissue perfusion. So decreased tissue perfusion is one of the main criteria or main pathophysiology leading to shock. And so decreased perfusion and cellular injury can then result in immune and also inflammatory responses. Next. Alternatively, elaboration of microbial products during infection or release of endogenous cellular products from the tissue injury can result in cellular activation to subsequently influence tissue perfusion and the development of shock. So this type of various microbial products or infective substances during infection can lead to some tissue responses which can release endogenous cellular products and then can ultimately lead to hampering tissue perfusion and development of shock. Next slide, please. This is the vicious cycle of shock. So when there is decreased cardiac output, and also there is another point is decreased tissue perfusion. Decreased tissue perfusion leads to decreased venous return, and on the other hand, it also leads to decreased coronary perfusion, which can lead to decreased cardiac output. And at the same time, decreased cardiac output decreases venous return, and it also causes metabolic acidosis, intracellular fluid loss, which ultimately leads to cellular hypotension. And on the other point, decreased tissue perfusion can also lead to parenchymal cell injury, and also there is endothelial activation or macrocirculatory damage, which can ultimately lead to cellular aggregation and perfusion, decreased tissue perfusion. So regardless of etiology, decreased tissue perfusion and shock results in a feed-forward loop that can exacerbate cellular injury and tissue dysfunction. Thank you, sir. So, in a nutshell, we can say that shock is the phenomenon which ultimately leads to decreased tissue perfusion. So, there is decreased oxygen supply or hypoxemic insults to various organs, which can ultimately lead to multi-organ failure. And so, pathophysiology of shocks can be of various types, that can be hemorrhagic, neurogenic, obstructive, traumatic. But ultimate end result is hampering of oxygen supply to various tissues and major organs, and which can lead to ultimately failure of multi-organ failure. Thank you, sir.
Thank you, Deeptaman, for your nice presentation. You have covered almost everything regarding the classification and the pathophysiology of shock. But regarding the classification, you have tried to group all the types of shock by the classification. But till now, there is no consensus about how we can classify in a very precise way, because there is overlapping of the features, overlapping of the etiology, overlapping of the clinical manifestation, and the effect on the tissues in various ways. So it can be classified, grouped, or classified in 3 different ways or 6 different ways. Whatever may be, the ultimately what is the end result, that the tissue cries because of lack of oxygen, and tissue cries because of the production of many metabolites, which are very harmful to the cells and tissues. So, so the target of the management of shock will be to keep the tissues in a healthy situation. So, to improve the healthy situation around the tissues, we have to improve the perfusion, and that is very, very important. And you have rightly said, and that is the most important factor, that the tissue should be protected by proper perfusion. And now we can pass to the next presentation. Then we can ask for questions from the participant. So the next presentation will be on probably on hypovolemic shock.
Sir,
Will be by, yes.
sir, one small request, sir. If Dr. Shrija can present before, because she has some clashing with her duties. So if we can have the third speaker
Okay.
before the second.
No problem, no problem. So we invite Dr. Srija to present on management of septic shock and recent advances. Srija,
Hello, good morning, sir.
yes, yes, please start. Srija,
Yes, sir.
please start.
How do I get this? Just a minute, sir.
I can talk to Dr. Kumar also. ఇక్కడ మాట్లాడొచ్చు I can ask that question. Hello. Hello.
Shrija, yes. Any
Sorry,
problem?
sorry. Yes, sir. I can't find it. Sorry, sir.
Can you send me the PPT?
Yes.
Just send me the PPT.
Hello.
Share. I have sent the PPT.
Okay, so in the meantime, we can continue some discussion. Suppose the classification of shock. Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
So you can classify the shock in 3 different groups, like hypovolemic shock, cardiogenic shock, and a low resistance shock. This low resistance shock that covers a big group of, that includes septic shock, neurogenic shock, anaphylactic shock, endocrine shock. Endocrine shock means the additions, myxedema, steroid withdrawal, everything. These features in septic shock, neurogenic shock, anaphylactic shock, the basic pathology is dilatation of the blood vessels. The total volume in the circulation is good, is normal, but because of the massive dilatation of the blood vessels, there is pooling of the blood in that spaces, blood spaces, and that will lead to shock, low perfusion of the tissues, and that is the low resistance shock that can be grouped in a different way. And the shock can also be broadly classified in two groups also, hypodynamic and hyperdynamic. Hypodynamic group includes where there is mainly cardiac cause. The cardiac output is less, vascular resistance is more. So that is the hypodynamic shock. Sija, are you ready?
Yes, sir. Yes, sir.
Okay, and hyperdynamic, that is the cardiac output is increased and vascular resistance is reduced. That is the hyperdynamic. So it can be, shock can be classified also as hypodynamic and hyperdynamic. Okay, Sija, start.
Yes, sir.
Septic shock.
Good morning, everyone. I'm Dr. Srija Rai from Peerless Hospital. I'm going to present septic shock. First, we need to know some definitions.
Hello.
First, we need to know about systemic inflammatory response syndrome. There are some criteria. Among these four criteria, if any two criteria is present, then we tell it systemic inflammatory response syndrome. The temperature is less than 36 degree or more than 38 degrees centigrade. Total count is less than 4,000 or more than 12,000, or more than 10% band form is present in peripheral smear. Respiratory rate is more than 20 per minute, and PCO2 is less than 32 millimeter mercury. Pulse rate more than 90 per minute without influence of inotropes. If any two criteria is present, then we call it SIRS. Sepsis is if there is criteria of SIRS is present and with a known foci of infection, then we call it sepsis. And septic shock is if there is sepsis causing hypotension that does not respond to fluid resuscitation, then we call it septic shock. Next slide, please. The risk factors for septic shock are diabetes, burn, neutropenia, invasive procedures and devices, intravascular catheter, cirrhosis, lymphoproliferative disease, etc. The common surgical causes of septic shock are burn, peritonitis, severe infection like gangrene, necrotizing fasciitis, cholangitis, etc.
Yeah.
Instrumentation of urinary bladder, septic abortion. These are all common surgical causes of septic shock. Pathophysiology of septic shock. Initially, the arteries and arterioles dilate, decreasing the peripheral arterial resistance. Cardiac output typically increase. This stage is known as warm shock. Even in the stage of increased cardiac output, the vasoactive mediators cause blood flow to bypass the capillary exchange vessels. So there is a distributive defect. Coagulopathy may develop because of intravascular coagulation with consumption of major clotting factors. For diagnosis, we can see for the symptoms of fever, there may be oliguria, there may be altered mental status. We need to do some blood investigations like complete blood count, coagulation profile, blood culture. We need to take at least 2 blood samples from different venipuncture site. Blood culture is the gold standard for detection of septic shock. If blood cultures are negative, then diagnosis depends on the Gram-Steinen culture of the primary site of infection. We should also do urinalysis. For treatment, we need to start antibiotic as soon as we suspect sepsis. First of all, we need to start parenteral broad spectrum antibiotic within the first hour of recognition of severe sepsis. Then we should narrow down the spectrum according to the culture and sensitivity report. Fluid resuscitation is very important. We need to catheterize the patient to monitor urine output. The target is at least 1 ml per kg per minute urine output. If the patient is not responding to fluid resuscitation, then we need to go for vasopressor. Noradrenaline or dopamine can be given. Noradrenaline, being more potent, is more effective in reversing hypotension in septic shock. Dose should be carefully titrated to maintain a mean arterial pressure of more than 60 millimeter mercury. Patients requiring vasopressor should have an arterial catheter placed at the earliest. We need to oxygenate the patient. If the patient is acidotic, then sodium bicarbonate may be given. One important thing is source control. Surgically, we need to drain the abscess, or if there is infected tissue, we need to debride that, or if there is indwelling urinary or IV catheter, we need to remove that. Glycemic control is also very important. CBG should be less than 150 mg per dl. Nutritional support is important, and if required, ventilatory support may be needed. If there is AKI, then renal replacement may be needed. Complications of septic shock: there may be ARDS, acute kidney injury, disseminated intravascular coagulation, mesenteric ischemia, myocardial infarction, liver failure, and ultimately there may be multiple organ dysfunction syndrome and eventually death. Multiple organ dysfunction syndrome occurs because of infection, inflammation, and hypoperfusion, which ultimately leads to decreased oxygen delivery and endothelial cell injury, leading to activation of macrophage and neutrophil with release of cytokines and other mediators. That ultimately leads to MODs. Now, I would like to speak a little bit about the recent advances. There is Sepsis 3.0 guideline. According to this, sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock is sepsis with need for vasopressor with serum lactate level more than 2 millimole per liter. The SIRS and severe sepsis terminologies are out. There are some other scores that we can monitor. One is QSOFA, Quick Sequential Sepsis Related Organ Failure Assessment Score. There, SBP is less than 100 millimeter mercury, that is, there is hypotension, altered mental status, and respiratory rate is more than 22 per minute, that is, there is tachypnea. If any two is present, then that indicates poor outcome. And there is SOFA score, where we check the respiratory system, hepatic system. For hepatic system, we check bilirubin, cardiovascular system, coagulation profile, central nervous system, renal system. For renal system, we check creatinine and urine output, and we also check Glasgow Coma Scale for central nervous system. And then there is a surviving sepsis guideline. The parameters to be met in the first 6 hours of resuscitation is central venous pressure should be 8 to 12 millimeter mercury. The mean arterial pressure more than equals to 65 millimeter mercury. Urine output should be more than equals to 0.5 ml per kg per hour. The mixed venous oxygen saturation should be 65% and superior vena cava oxygen saturation 70%. Thank you, sir.
Okay, Srija, thank you. You have covered many things on the septic shock. And remember that septic shock is a type of shock which covers almost all the etiology leading to shock. That is, septic shock is the shock where you will get the hypovolemia. You may get the hypovolemia. You may also have the effect on the shock due to the effect on the cardiovascular system, on the nervous system, because infection itself affects the heart and the brain. So ultimate effect will be multifarious. So if you know the septic shock properly, you know almost everything about the shock. So initially the septic shock is a warm type of shock. Later it becomes the cold type. Why? Why? Because of severe vasodilatation at different parts. Okay, if there is and all the circulation from the skin will be redirected towards the system, vital organs. For that reason, the warmth of the skin will not be present. And remember, initially you mentioned that the arterial pressure should be maintained at 60 millimeter of mercury. And in the recent advances, you have mentioned it should be 65 millimeter of mercury.
65, yes, sir.
65. So actually, standard teaching is 70 millimeter of mercury. So for everyone, we should remember that still the standard mean blood pressure should be maintained at 70
70.
millimeter of
Okay,
mercury. And regarding the source control, you have covered the abscess drainage.
Abscess drainage, debridement of necrotic tissues, and removal of indwelling catheter or IV catheter.
Anything, there are so many things, you know, all of you know, different causes of sepsis. So all, including these three, you have to cover also many things. How you
Yes,
can
sir.
control sepsis. Can you mention few of them?
If there is peritonitis, patient is going to shock for peritonitis. If there may be intestinal perforation, we need to operate that. If
Gangrene.
there may be
Suppose
infected
there is-
hematoma.
Yes, suppose there is a volvulus, gangrenous volvulus. Until
Yes,
unless even if the patient GC is very poor, you may not establish any anastomosis. At least you have to bring out the gangrenous gut outside the
Yes, sir.
abdomen and resect it. And you can keep the patient on stomas. So
Yes,
you
sir.
have to remove the gangrenous bowel. And the
Yes, sir.
cause of sepsis may be also the infection of the organs like pancreatitis, severe pancreatitis.
Pancreatitis.
Okay, so pancreatitis, you know, there are so many enzymes are released from the pancreas. So pancreatitis initially, that is, it causes the chemicals. It is liberating chemicals. Later, when it is secondarily infected, then it will not only lead to the endocrine shock or the chemical shock due to the chemical product secretion, but also due to infection. Okay. And
Yes,
you have mentioned SARS, you have mentioned MODS. What is MOPS? MOFS? What is MODS? Multiple organ
dysfunction syndrome.
What is MOPS? MOFS? That is sometimes asked in the exam. What is MOPS? And that is also written in Bell Lab's book also probably.
I don't know, sir.
That is multiple organ function MOPS syndrome, organ failure syndrome.
Failure syndrome.
Dysfunction leading to failure.
Failure.
So dysfunction is a stage before MOPS. Once there is MOPS, almost it is irreversible. Even at the stage of MOPS, you can treat the patient, you can manage the patient to save. But once the patient leads to MOPS, almost in more than 90% of patient cases, you cannot make the patient survive. Okay. And all the postgraduate students should remember SOFA score, that is very often asked in the exam. And urine output, you have rightly mentioned in the recent advance. Usually the standard teaching was it should be 1 millimeter per kg per hour. But now in recent advances, it is said, it is mentioned that it should be 0.5 ml per kg per hour. That is very important. And so these things I like to mention. So we can pass to the next speaker if he is ready.
Thank you, sir.
Dr. Behrul,
Yes, sir. Yes, sir. Good morning, sir.
please share your screen.
Yes, sir.
Thank you.
Main problem with the mandal last is already petanu, but
Am I visible to all?
and the
Hello. Hello. Am I visible to all? Hello.
Yes, Behrul,
Yes, sir.
your slides are visible. You can start now.
Okay, sir. Good morning, sir. Myself, Dr. Behrul Vada from Southeastern Central Railway Hospital, Kolkata, and I'm here to present management of hypovolemic shock and recent advances. In hypovolemic shock, basically there are two types of hypovolemic shock, that is hemorrhagic and non-hemorrhagic. In hemorrhagic, hemorrhagic mainly occurs due to external hemorrhage that can be due to trauma, hematoma, or internal hemorrhage like in GIT bleeding. In case of hemothorax, hemoperitoneum, in GIT bleeds can be due to upper GI bleed and lower GI bleed. And the non-hemorrhagic causes are external like vomiting, diarrhea, polyuria, dehydration, burns. And the third is the third space loss that occurs in case of pancreatitis and bowel obstruction, and ascites. In hemorrhagic shock history, the patient gives the history of hemorrhagic shock, in which we usually get systolic blood pressure less than 90 mm of Hg, and mean arterial pressure is less than 60 mm of Hg, and serum lactate is more than 2 millimoles per liter. And the hemorrhagic shock is the leading preventable cause of death in case of trauma patients. For management of this patient, first we have to carefully assess the patient by physical examination and by laboratory tests. In a physical examination, first of all we have to recognize the body, the bleeding points, or search for the source of bleeding, from where the patient is bleeding. Like in case of fracture, the patient might be bleeding from the open fracture site, or in case of laceration injuries, free bleeding can be occurring through the laceration site. And for this evaluation, we have to carefully examine the patient from head to toe, and we have pelvic examination in case of obstetric patients, and the repeated careful physical examination and monitoring of vital signs is necessary. We can classify the hemorrhagic shock in 4 classes, depending upon the amount of blood loss and the normal vital signs. That is, in case of class 1 hemorrhagic shock, blood loss is up to 750 ml. In case of class 2, that is 750 to 1500. In class 3, more 1500 to 2000 milliliter of blood loss. In case of class 4, more than 2000. And accordingly, percentage wise, in class 1 up to 50%, class 2 50 to 30%, in class 3 30 to 40%, in class 4 40%. In these scenario, in class 1 we get normal blood pressure, while in class 3 and 4 we get decreased blood pressure. While in respiratory rate rises much more in case of class 4, that is more than 35, while in class 2 and class 3 it is 20 to 30 and 30 to 40. And the thing which you get by examining the patient physically, that is in center, the patients will be slightly anxious in case of class 1 hemorrhagic shock, while in class 2 it will be mildly anxious, and in class 3 and class 4, in class 3 he will be confused, and in class 4 he will be confused and lethargic. So we can easily assess these things by just seeing the patient and examining the patients by central nervous system. And after that, we have to do the laboratory investigation, in which we'll do an ABG, and it is the most useful laboratory test. In the ABG, we will get a metabolic acidosis, that will pH will be less than 7.35, and the lactate level will be elevated. And this indicates that the tissues are performing anaerobic metabolism for their needs. So in anaerobic metabolism, the lactate level rises, and in hemoglobin and hematocrit level is not useful for much in case of diagnosis of shock. In the hemorrhagic shock, we will get low hemoglobin level, and we also have to do the coagulation studies and electrolytes studies. In hypovolemic shock, we will usually get low electrolytes and low level. And for diagnosing the site of the bleeding, for chest, we can do bedside chest radiography and thoracostomy tube output. For example, in case of abdominal examination, we can do EFAST, that is used nowadays, and peritoneal lavage and long bones we can easily get by physical examination and plain radiograph that there is bleeding occurring or not, and outside the body by general physical examination, and that there is any active bleeding present or not present. And for the initial management part, we have to secure the airway, breathing, circulation, and we have to stop the bleeding that is occurring by applying tourniquet or by manual compression of the bleeding point. And after that, we have to, if there is any bleeding occurring due to arterial damage or venous damage, we have to clamp, and further we have to ligate that bleeding point. And after that, we have to maintain the blood pressure level by administration of fluids. That is, initially we have to give crystalloid to the patient, and as there is much amount of loss in cases of hypovolemic shock. So the patients, so also we have to warm the patients. So the trauma patients are approached systemically using the principles of primary and secondary survey. And ATLS emphasizes that the ABCD in the morning, that is airway, breathing, circulation, disability, and exposure. And ATSLS is based on simultaneous effort to identify and treat life and limb-threatening injuries, beginning with the most immediate. After the primary survey, when the patient is stabilized, a more deliberate second examination is taken, and any remaining injuries are diagnosed at this time, and treatment plans are established. So the initial measure is to pressure to the bleeding part, elevation of the bleeding limb, so that the most of the blood goes to the heart, and the application of the tourniquet, and the immediate placement of chest tube in case of hemothorax patients, and splinting of the fractured extremities, and by manual uterine compression in case of PPH patients, you have to do that, or administration of oxytocin and uterine evacuation. And for managing the patient, the initial fluids will be warmed isotonic crystalloid solutions are used, and the initial dose will be 1 to 2 liter for adult, and at 20 milliliter per kg for a pediatric patient. The advantage of using crystalloid solution that is easily available, cheap, and it is very much safer, and initial losses are replaced with crystalloid solution. And the disadvantage of using the crystalloid solution is that rapid movement from the intravascular to the extravascular space occurs, leading to 3 or more times requirement of replacement and resulting in tissue edema. Next is colloid solutions, more effective in rapidly restoring intravascular volume, requiring less fluid to correct hypovolemia. It includes albumin, hydroethyl excess starch, dextrine, and gelatins. The limitation there, this carries risk of reaction and it is also very much expensive. Then, nonetheless, the interstitial fluid deficit associated with hypovolemic shock may be better treated with a crystalloid solution or combination of colloid and crystalloids. In replacement fluid, ringer lactate is preferred over NS to avoid hyperchloremic acidosis, and it is slightly hypotonic in large amount and can aggravate cerebral edema. And the second choice is hypertonic salt solutions like 3% and 7.5% normal saline. It causes less cerebral edema, and it's in a small volume. It rapidly expands plasma volume. And the dextrose containing solutions should be avoided because already in trauma patients there is less oxygen going to the blood, and it also exacerbates ischemic brain injury. So the adjuvant therapies will be supplemental oxygen, mechanical ventilation, prevention of hypothermia by warming the patients, treating the electrolyte imbalance, specifically hypocalcemia, hyperkalemia, hypomagnesemia, and correction of acid base abnormality, that is severe metabolic acidosis, and early treatment of hyperglycemia, and in corticoids might require in case of adrenal failure. And the goal of resuscitation will be maintain systolic blood pressure at 80 to 100 mmHg and hematocrit level to 25 to 30%. And the core temperature should be maintained by higher than 35 degrees Celsius, and oxygen saturation should also be maintained, and normal urine output, and prevent increase in serum lactate, prevent acidosis from worsening also. So risk associated with the aggressive volume replacement during early resuscitation, that is increased blood pressure, decreased blood viscosity, decreased hematocrit, decreased clotting factor concentration, disruption of electrolyte balance, direct immune suppression, increased risk of hypothermia. And this is a chart of resuscitation response to initial fluids that if we give, there is a rapid improvement, transient improvement, no improvement. So, and we can also after in case of hemorrhagic shock, we have to transfuse blood and other products so that easily the blood pressure should get maintained. With the hemorrhagic shock, blood can be life saving. That is, we have to decide when to transfuse, when not to transfuse, and what to transfuse, what not to transfuse. Like in so if hemodynamic instability persists after approx 2 liter of prescribed infusion. So decision of transfusion of PRBC whole blood should be taken. If this was constant setting, the admission of precious unit of blood should be delayed until hemorrhage is controlled. Use blood as a part of preoperative resuscitation when possible. So indication of blood component therapy. Packed RBC should be used for replacement of oxygen carrying capacity, and platelets should be for thrombocytopenia and bleeding prevention. And fresh frozen plasma should be used for documented coagulopathy. So what is the advantage of whole blood versus component blood? That the whole blood does not require special any equipment for processing, and it is easily available, and it supplies both all the things like plasma volume, red cells, platelets, and coagulation factors, so thereby potentially avoiding the coagulopathy often seen in hemorrhagic shock. So there's a massive transfusion protocol in which we replace 1.5 blood volume in more than 10 units of blood volume, more than 10 units of PRBC in 10 units of PRBC in 24 hours, or more than 4 unit of PRBC or whole blood in 1 hour. And indication is unresponding unstable patient who has already transfused 2 units of PRBC with initial resuscitation. It minimizes dilutional coagulopathy, and the ratio should be 1:1. That is 1 unit of FP, 1 unit of platelet, 1 unit of PRB should be subsequently transfused. And even after doing all these things, if the blood pressure doesn't get maintained, so we have to use the vasopressors like adrenaline, non-adrenaline, dopamine, and so the CVP should be less than more than 8 centimeter of H2, and mean arterial pressure should be more than 60 mm of HGP for successful resuscitation of the patient. If these things are lying below the normal levels, we have to use the vasopressors. And in case of all these things, there is another thing, that is damage control resuscitation, in which a systematic approach to severe trauma is used in incorporating several strategies to decrease mortality and morbidity. And the components are permissive hypotension, after that hemostatic resuscitation, after that damage control surgery is done. And acute life-threatening bleeding within the abdominal or thoracic cavity is the indication for operation of the patients. And after that, we have to, after doing all these things, we have to monitor the patients. And there's 2 types of monitoring system, that is non-invasive monitor and invasive monitor. In non-invasive, that is, we have to use ECG, BP curve, pulse oximeter, ETCO2, temperature probe for measuring the core temperature of the body, and Foley's catheter to measure the urine output, that successful resuscitation is going or not going on. And in invasive monitor, there is an arterial line for blood sampling, that is, and BP monitoring, and central venous catheter placement to measure the volume status of the patient. And pulmonary artery catheter can also be used in case if patient shows signs of heart failure. And in recent advances, we have got blood substitutes in case of that PRBC whole blood is not available. The research is going on to develop perfluorocarbons that can replace hemoglobin, that can replace whole blood system. And the second generation is stoma-free hemoglobin, and next generation blood substitutes are pegylated hemoglobin and hemospan, and pyridoxalate or hemoglobin polyoxycline conjugate. Thank you, sir. Hello.
I think, sir, you're not audible.
Hello.
Borul, thank you for your nice presentation. You have covered so many things in hypovolemic shock. I will appreciate your part, particularly in monitoring and the management of the shock, hypovolemic shock. And I can ask for the comments or questions from the participants, and also the teachers. Particularly, I can see some teachers are there in the seminar. You can make your comment and your question, if any.
Hello.
Hello. Any comment or any questions from the audience?
Hello.
Hello.
Sir. Hello. Am I audible, sir?
Yes, yes. Dharma.
Sir, this is Rupesh, sir. I'm a general laparoscopic surgeon. So I'm working in Tirupati, sir. So, I mean, whole topic is very good, but slides are very overloaded. And I mean, 3 members presented the seminar.
You are audible, but it is masked. Voice is not clear. I don't know. If anyone can hear, then can explain me. Then tell me what he is telling.
Dr. Maiti, Shukumadda.
Yes, Manju.
Manju here.
Manju, yes, voice.
He is saying the material is very good, the topic is very good, but the slides are overloaded and they are gingy. They are
That's
lots of things are written on one slide.
That's true.
Right.
That is very true. That is very true. But whatever may be, we are more concerned about the materials. Materials are good. Slides are really large number of slides are there. That should be very number and in content that should be less. But topic he has nicely covered. Any more comments about the subject?
Rupesh. Hello, Rupesh. These children talking on shock. They are small boys. They are students, and they have been given a very limited time. Shock is a very huge chapter, and that's why they have tried to fill in whatever knowledge they want to distribute in slides. You are right in saying that the slides are gingy, and that's our job as teachers to tell them how to make slides, which will be a part of their teaching later on. Okay?
Madam, give me a second, just one question.
Yeah.
Why should we, I mean, when we start dopamine, when we start adrenaline, double dose norad, vasopressin, dopamine, and how to, I mean, it depends on the BP, but how can we assess the trauma-induced coagulopathy? That is my main question, madam. Trauma-induced coagulopathy.
Rupesh, can you please type your question into the chat box so that we are able to read out, because your audio
You're
is
right,
very
right, and then we're discussing some other aspect. Then we'll come back to your question. Okay.
Yeah. Shukumada, you can continue.
Okay. You see, Baharul, you have mentioned, you have classified, you have rightly mentioned the loss of blood, and you have classified the hypovolemic shock accordingly. That is stage 1, stage 2, stage 3, and stage 4, class 1, 2, 3, 4. And 40% is the large landmark where it is the class 4 shock, 40% loss of the total volume. But remember, if it is 50%, the patient will be totally unconscious. So
Yes,
once the patient is unconscious, remember, probably the patient has lost more than 50%. So the management should be very aggressive. Okay.
Yes, sir.
And in the management of the hypovolemic shock, you have rightly mentioned, sometimes we have to find out if there is a coagulation disorder, if there is associated infection or sepsis, there may be DIVC. So DIVC will lead to further bleeding, and then the replacement should be properly with blood and coagulation factor. FFP and cryoprecipitate, you have rightly mentioned, those are very sometimes important armament in the hands of the clinician to manage the hypovolemic shock, particularly when it is associated with sepsis.
Yes.
And as in the management of hypovolemic shock, we should also include some other procedures which sometimes may be needed embolization. Suppose if there is internal bleeding, or hemophilia is a condition where there is communication between the arterial and the your drainage system, drainage system. Then there is severe bleeding. By planning operation to ligate the hepatic artery branches is very difficult sometimes, but embolization is technically a very efficient procedure by which you can control severe hemophilia, or if there is severe bleeding from the mesenteric blood vessel into the intestine, you can embolize the branches of the superior mesenteric vessel sometimes. That is very, very important. And even bleeding from the gastric ulcer by use of laser and other techniques or injection therapy for varicose vein, and you can or banding of the varicose vein. Those are the procedures we should
Yes.
remember also.
Yes.
And regarding the investigation, we have mentioned everything in case of hypovolemic shock, but also the endoscopy, as I have mentioned, the isotope scan,
Yes, sir.
and the peritoneal tap. Suppose
Yes,
in
sir.
trauma cases, peritoneal tap is sometimes needed, and ultrasound and CT scan we should not forget.
Yes, sir.
Anything more? Any question?
I've typed some questions in
Dr. Rupesh has asked the question it's in the chat box. He has asked, how can we assume whether the patient is having trauma-induced coagulopathy or not? And what is the what fluid should we give in that case? NS or RL or Hemaxil?
I mean, even in trauma or even in burns, the people are fighting with the NS and RL.
So he wants to ask the fluid for resuscitation. What is the preferable fluid of resuscitation in this case?
Till now, the Ringer's, if the blood is not available, till now the Ringer's lactate is the preferred fluid which should be supplemented. And in the meantime, if possible, you can have a prompt measurement of the serum electrolytes, and then you can modify your fluid replacement. Ringer's lactate is ready at hand, and that will not cause too much harm. Rather, that will cause good to the patient until and unless you get the blood for blood loss. Okay, still now our standard teaching is Ringer's lactate, I think. Anything else? Any more question in the chat box? Milind, can you say? Just you tell me, and then we can discuss.
No, sir. This was the only question in the chat box.
Okay. So in summary, in the treatment of the shock, we should remember that always don't forget your ABC. Okay, so and the emergency management, we should always take care of that. Circulation, airway, circulation, these things should be given the priority. And in septic shock, infection is the primary factor. So initially you start the medical management. If the surgical management is needed, you should not make delay in giving the surgical management. And always identify the patient who are at high risk for the shock. Control and eliminate the cause of the shock. If there is hypovolemic shock due to the bleeding, your priority should be to stop bleeding. One thing I must mention, when there is a patient is in dire shock, and if the blood is not available, when there is more than 30 to 40% loss, you can use the pressure stockinette to the limbs, to the lower limbs and upper limbs. You can temporarily apply the pressure stockinette with optimum pressure so that circulation from the limbs are directed to the trunk, particularly to the heart and the brain. And so in every way, you have to take the measures to enhance tissue perfusion, particularly to the perfusion to the heart and the brain. And acid-base balance, that should be corrected. Always remember heart, particularly if it is in an elderly patient, if the shock is an elderly patient, you should take special care about the heart. You should find out whether the patient is having any associated cardiac ailments. That should be corrected. If particularly dysrhythmia, that should be corrected. And early intervention, and always early intervention is to be made if it is needed. Prompt recognition and treatment make always a difference in the outcome. So every shock should be taken with care. And if you can recognize the etiology, if you can recognize what is the stage of pathophysiological changes when you are examining the patient, then you can plan quickly your management. Thank you. Manju, if you like to say anything, Devashish Kundu, Manju, if you like to say anything, please comment, then we can conclude the session. Milind,
Yes, sir.
so if there is no question and time is close to 9, so let us stop, and thank you all the speakers and the participants who are present in this seminar. And
Thank you, sir.
we are unfortunate that we could not get our very beloved and respected teacher, Dr. Professor Makhurlal Saha. He is now on the way to Maharashtra. So we missed his deliberation and missed his comments in this seminar. Thank you all.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.